Dr. Daniel Ontaneda is a neurologist and professor of neurology at the Cleveland Clinic's Mellon Center for Multiple Sclerosis, and he's the co-principal investigator of the Deliver MS trial, which tackles one of the biggest questions for people who are diagnosed with MS. Should we start treating MS with the most powerful drugs immediately or escalate as needed? It's good to see you, Dr. Ontaneda.
It's great to see you, John.
You've described Deliver MS as a test of two different philosophies rather than just two drugs. For someone who's newly diagnosed today, what's the most compelling piece of evidence that you've seen so far that might suggest we should hit hard and hit early?
Yeah, that's a great question, and I think it's something that almost every day I see in clinic, and I think people who have been recently diagnosed with MS, one of the first things we talk about once we confirm a diagnosis is, well, how are we going to treat the disease? And the reality is that we've got over 20 medications, and it's a little bit complicated, and I think for people recently diagnosed with MS, it can be really confusing. And sometimes it's easy to break it down, and I think the trial breaks it down, and you just broke it down yourself, which is, you can do a stepwise approach where you start with low efficacy medications, and only if you need to do you move on to the more powerful medications. And the overlying phenomenon there is that maybe if you use lower efficacy medications, perhaps you have a little fewer risks initially when using the medications, versus high efficacy may be associated with some increased risk. Now, I think the MS field has changed. When we started the study, I would say things were probably 50-50, even at MS centers, where people said, well, I'm not really sure what I should be using, escalation approaches or highly effective approaches. Now I think that if you talk to most MS centers, people will generally say, we generally advocate the high efficacy medication. And that's based mainly on two sources of information. On the one side, it's actually randomized clinical trials, where people are either randomized, flip of a coin, exposed to a low efficacy medication, and that's compared with a high efficacy medication. And when you do that, it's clear that people on the high efficacy medication do better. Now, you have to understand that that's a trial, and that many times in clinical practice, we're not just leaving patients on a low efficacy medication. That is, we're escalating quickly. And so it doesn't really exactly capture what people do in practice. And then gives us to the second piece of data, which is observational data. So here in observational data, it's not a randomized clinical trial. We just take people out of our practices and perhaps out of registries, and we compare people who started escalation approaches versus those that started highly effective approaches. And generally that data shows that the people who are on the high efficacy medications tend to do better. But the problem is that it's observational data. So on the one side we have clinical trials that are imperfect. On the other side we have observational studies that might have some bias associated with them. And so I think really to answer the question definitively, we need randomized clinical trials. And that's what Deliver MS is doing. Although we did the study because we think people on high efficacy are probably going to do better, that's what we're trying to demonstrate. And at the end of the day, the trial could go either way. And to be honest, I wouldn't be super surprised one way or the other. But the reality is that the most important thing is that patients start on some medication and that they monitor and make sure that it's working for them and that it's safe for them.
Your study uses brain volume loss, or atrophy, as a primary way to measure success. Should a patient care more about their brain volume on an MRI than just the number of new lesions that MRI may show?
Yeah, that's a great question. So when we were designing the study, we had a couple options. One option was we could focus on, for example, how many new lesions a person might develop on a treatment. And I think if you do that, you'll pretty much know what the answer is going to be. The high efficacy medications will probably block the lesions a little bit better. And it's probably the same for attacks. And the reality is that attacks probably are going to do better on high efficacy medications. What we were interested, though, was in a long-term question. Not attacks, not MRI lesions, but what does a person's disability look like 10 years after they started a medication? We would have loved to do from the get-go a 10-year study, but they gave us 3 years to do the study. And so in a span of 3 years, we said, well, what is the measure that is probably best at early on predicting how a person's going to do from a disability standpoint? And that's why we selected brain volume loss. We had to do a lot of work, and we got in rooms with people with MS, and we asked them, do you think that, brain volume loss, that is the rate at which the brain is slowly losing volume, do you think that is something important for people with MS? And the resounding answer was yes. people care about this. You know, we think time is brain, we think, of course, the brain is valuable, and it's natural to think that if you're preserving brain volume, you're probably going to do better in the long run.
You've looked at how drugs like ocrelizumab do in the real world compared to controlled trials. What's the one thing patients do in their daily lives that most impacts how well their medication actually works for them?
Yeah, this is a great question also. You know, whenever we talk about treatment of multiple sclerosis, we talk about not just medication. I think treatment of multiple sclerosis is something holistic and is something that involves not just the medication. It involves everything we do in our lives. And I think what we know is that people do the best when they combine an effective medication for MS and monitoring to make sure the medication is working, and at the same time they're doing all the other things to keep their brains healthy. This is probably things that are important for everyone to do. However, when somebody's diagnosed with MS, we talk about it. So what does that include? That includes making sure that your diet is balanced, and we generally recommend a heart-healthy diet, which is lots of fruits, lots of vegetables. Don't eat a lot of processed food. Don't eat a lot of food that has a high salt content, because we know that those probably don't help MS. It also includes exercise, regular exercise. It also includes management of stress levels, which we know can be hard for all of us in our lives, and you know, even more for those people who are stressed about a recent diagnosis of multiple sclerosis. So we provide tools for that. And I think if you combine these healthy wellness approaches with a medication that we think works and is monitored correctly, that will probably optimize your best response. And then of course we ask people to be cautious and make sure that they report any side effects with the medications, because we have to know about those to make sure that the balance between controlling the disease and the risks sometimes that are associated with the medications is taken care of.
You and I have talked about this subject before, and you've suggested that the traditional buckets for MS, relapsing remitting, secondary progressive, primary progressive, might be outdated. If we move away from these labels, how will that change the way a doctor decides which treatment is right for the patient in front of them?
Yeah, that's a good question also. And I think what we need to try to do is stay away from the labels or the buckets and describe what are the processes that are present in a person's multiple sclerosis. And we know quite well that certain treatments are really good for certain processes that we find. And the very clear example here is, for example, the presence of new MRI lesions, the presence of MRI lesions that are active. Those are measures clearly of inflammation, and those measures typically respond to an anti-inflammatory treatment. And so you might ask me, you know, do I care about the label? No, not so much. I care about if a person has demonstration of inflammation, whatever they were labeled with, I think they probably would benefit from one of these anti-inflammatory medications. As we're trying to develop medications that might target that more slow worsening, what we call progressive MS or progressive biology, it stands to reason that when we're able to identify that, we should use medications that are effective for that. Do we have medications right now that are effective for that? We're still searching. There were some promising leads, and I think the field is still undecided if medications are available right now, but certainly we have a very long list of potential therapeutics that might be targeting that slow worsening of MS, and we have to test them. And once we identify something that works, then the idea is you treat what you can see biologically.
To that point, we've heard a lot about progression independent of relapse activity, shortened to PIRA. How do we catch this progression earlier so patients don't wake up one day feeling they've lost ground despite having a stable MRI?
Yeah, good question. I encounter this almost on a daily basis with my patients. And the reality is we do an MRI every 6 months on people who are treated, sometimes every year, sometimes every 2 years. And we monitor for the presence of relapses. And many times we see no MRI lesions, no active inflammation on the MRI, no attacks. But when you ask the patient, how do you feel? Many times they notice that there is a gradual worsening, and that gradual worsening can occur in spouts. It occurs and then it relieves itself, and then they're stable, and then it can worsen again. And so it's somewhat of a fluid process. And the reality is that you can't pick up that, what we call progression independent of relapse activity, unless you're looking for it. How can you look for it? Well, we can just ask people how they're doing. I think that's one technique. You can ask them with something called patient-reported outcomes, and perhaps you can do even more detailed testing than we normally do. We think about detecting progression maybe by changes on something called the EDSS, and that probably will detect a small proportion of individuals who are worsening. But if we, for example, take a test based on a digital device that somebody is using that's measuring their walking speed, or is measuring the distance they walk, or perhaps is measuring some physiologic function that might be changing, we might be able to much more readily assess individuals who are worsening. And it's important to do that because you want to identify that worsening early, because we want to put them on something. We want to treat them symptomatically to improve the symptoms that might be worsening. So I think the bottom line is you have to look for it. And this is the analogy kind of the iceberg, right? And so what you see at the very tip is maybe kind of what was historically we've considered worsening MS. But the more you look, there's something that's below the waterline of that iceberg that might demonstrate some worsening.
As an imaging expert, you're a major proponent of using the central vein sign to make MS diagnoses faster and more accurate. How does this tool help a patient avoid the familiar diagnostic odyssey of being told they might have MS for a period of years?
Yeah, the diagnosis of MS is sometimes very straightforward, but many times it's not. And many times you have individuals who might have spots in their brain that somebody has said these are suspicious for MS, and many times have to be followed over years before a diagnosis of MS can be confirmed. The central vein sign is a special type of MRI tool because it allows us to identify if spots in the brain are related to multiple sclerosis or not. The presence of a vein in the middle of a lesion actually relates to the fact that those lesions occur around the blood vessels. That happens in MS, but it doesn't happen in other conditions that might mimic MS. Migraine, small vessel ischemic disease or small strokes, other inflammatory conditions can have spots in the brain, but they typically do not have the small vein going through the middle of the lesions. So if at the get-go you can do an MRI and find these lesions, you can be pretty sure early on that it is indeed MS. And that's in the new diagnostic criteria. Sometimes might save you from having to wait and do repeated MRIs. Sometimes might save you from having to do a lumbar puncture.
A lot of people are going to be very happy to hear that for sure. We're hearing that rim lesions might predict a more aggressive disease course. If a patient sees this on their MRI report, should they be asking for a different treatment strategy?
Great question. I think the reality is that these paramagnetic rim lesions are a marker of perhaps a different type of biology in MS. And it's the presence of what we call chronic inflammation. That's inflammation that isn't like the typical inflammation we talk about with new lesion formation. These are lesions that might already be there that have a rim of inflammatory cells around them. We think that that is different. And we know that people who have rim lesions, the more rim lesions they have, it's more likely that their MS might worsen over time. I would love to have a treatment right now at my disposal that I could say, yes, you have rim lesions, I'm going to treat you with this medication. We had some initial signals on some medications within the BTKI family that appear to respond better in people who had rim lesions, or there was actually, what was found was that the people who had rim lesions were the ones that most benefit from the medication. However, the overall status of that medication right now is still being discussed with the FDA. I do think that in the future, we will be able to identify a group of therapies that might be specifically good for this chronic inflammation. And then certainly I think presence of these rim lesions might be a way of picking who would benefit from that medication. So in the future, short answer, John, I think it'll be with us soon.
While we're looking at the future, I've heard you call remyelination and repair the next frontier for 2026. What's one trial or technology you're hearing about that you think will finally move us from stopping damage to fixing damage?
Yeah, well, I think the remyelination field right now is really grown and developed. There are a multitude of medications that right now are transitioning from what we call basic science animal models of MS, moving into actually first in human studies, and some medications that are actually quite advanced in terms of the clinical trial development. we've seen a lot of promise in this area. And this promise is based on developments in the basic science world, where you can actually target cells called oligodendrocytes and see how medications might affect those oligodendrocytes. Oligodendrocytes are the cells that make myelin. And if we can promote these cells to produce more myelin, well, it's natural to think that if you use a medication like that in a patient, we perhaps can build up some myelin that might have been lost. So lots of different compounds. I think what we need to figure out right now is what's the best strategy to test these medications. There's different ways to do it. You can do it in people who maybe have had MS for some time, and you look at them because they have a chronic lesion in their optic nerve. You might think about doing it in people who've been recently diagnosed with MS with active lesions. My personal opinion is that the earlier you try these therapies, probably right after an inflammatory attack, you'll probably get the most likelihood that you'll be able to potentiate remyelination. But these are all questions that are really good. I will say that I would remain very positive based on the number of medications and the pathways that we've actually discovered. I think that remyelination therapy will be a reality soon.
I always learn so much every time we talk. Dr. Daniel Ontaneda, I want to thank you for all you do in the lab, in the clinic, to help people living with MS live better with MS. And thanks so much for talking with me today.
Yeah, thank you, John. It's such a pleasure always to talk with you. And I just have to reflect that the content that you create is so meaningful and impactful, not just for people with MS, but also for us as clinicians, and seeing how you connect is really special.
Thank you.
All right, thanks, John.